Hello, I'm assuming you all can hear me. Um, this is the new technology. I'm using StreamYard, but I'm assuming you all can hear me and see me. Um, Good evening. My name is David Hefner. I am the inaugural vice president, as it were, for online education, having assumed the position in January. I want to thank the extraordinary work of your program director, Dr. Waldrop, the work of the entire staff, and the work that you all in the faculty and the work that each of you all have made toward the success of this journey. In 1975, when Morehouse School of Medicine was founded by then President Dean Lou Sullivan, and under the mentorship of Hugh Gloucester, the president of Morehouse College at the time, we envisioned then where we are today. This doctoral program, the Doctor of Health Care Administration, is the third doctoral program in the history of Morehouse School of Medicine, and we're only 50 or almost 50 years old. And so the class, this inaugural class, the 12 members of this cohort is making history. And we have very, very ambitious goals and dreams for what y'all will be, what y'all are already, and what this doctoral degree and a doctorate will allow you to do in terms of advancing your careers and your professions. I just want you to take a moment to think about your journey to this point. This is the end of the journey, the end of one chapter and the beginning of another one. And so I'm eager to hear and observe the Capstone projects. As administrators, we are problem solvers. That's what we do. Our job is to ensure that whatever organization we lead, we provide the necessary resources, eliminate the barriers so that excellence can be performed, whether it be through patient care, at the academic level, whatever the company might be. So again, I just want to welcome and thank you all for all the work that you've done thus far. Again, thank Dr. Waldrop. I've been at the institution for 10 years. When President Montgomery Rice asked me to assume this role, we knew that we were going to take this program to even greater heights. And so I look forward to sharing with our graduates and our students the vision for where this program will go in the next 3 years. So without further ado, again, I send you greetings and wish you well. I look forward to listening to your capstone projects. Thanks a lot. Bye-bye.
Thank you, Dr. Hefner. Good evening and welcome everyone to this evening's Spring 2025 Doctor of Health Administration Capstone Oral Presentations. I'm Renetta Waldrop, Associate Professor and Inaugural Program Director for the DHA program, also currently serving as an interim dean for online education and expanded programs. Tonight, our Cohort 1 scholars who entered the DHA program in the fall of 2022 will complete the last assignment and presentation of their 3-year doctoral journey. Their culminating project, a solution-focused capstone, will showcase their ability to identify a problem related to healthcare and to research and recommend a solution that is industry feasible, patient-centered, and administratively sound. Tonight, in TED Talk style, you will hear only a fraction of their research, a compelling story that sets the stage for the problem, a statement of the problem itself and its magnitude, what the literature has revealed to them, and their recommended solutions. For those of you wanting to learn more, their full capstone research project in the form of a white paper will be made available in a digital repository through the MSM library. I want to thank Mr. Swanson, Dr. Simpson, and Dr. Wellmaker for making this option available. I also want to thank all of our faculty and OEEP staff who have supported our scholars, and in particular, their faculty advisors who have served as capstone coaches guiding them to this final stage of their journey, as well as their subject matter experts who provided industry-related advice. Thank you also to Ms. Blake Crosby for her expertise and assistance in making this virtual platform available to all of us tonight. Tonight's presentation scholars are Keisha Bentley, who will be followed by Trishina Stokes, who will be followed by Pamela Woods. Once they have completed their presentations, the floor and stage will be opened up for Q&A. After Q&A, we will be followed by Dr. Dorothy Boldrick, DHA Assistant Professor, who has been with this cohort since day one. That was a mere 934 days ago, for anybody who was counting, who will give closing remarks. So thank you all for being here and for your support of our DHA scholars. With that said, Ms. Bentley, your TED Talk audience awaits, and the virtual TED Talk stage is all yours. Thank you.
Good evening. I'm Keisha Bentley, and it gives me great pleasure to present to you It Takes a Village, addressing high maternal mortality rates and postpartum care in rural minority communities in the Deep South of the United States. Close your eyes. Bring to mind the women and girls in your life, the ones who hold a special place in your heart. Perhaps this special lady is your wife, mother, grandmother, sister, aunt, friend, cousin, or even a daughter. Think of who they are to you, what they mean to you, how they add to your life. Reflect upon your happiest moments with these special people. Remember the birthdays, graduations, holidays, and other celebrations. Think about the times they were there for you when you needed them most. Consider the plans you have coming up. Are there family or friend trips on the horizon? Maybe there are weddings and other important moments that you're looking forward to, so you can create new memories. With your eyes remaining closed, what feelings or emotions come to mind when you consider these special ladies? Is a smile on your face? Do you feel the warm fuzzies in your heart? Maybe there's a tear of gratitude that has begun to well. What a blessing it is to have fond memories of and with those you love. Now, take these moments that you see so vividly in your mind and erase those special people. These people who you love and cherish so dearly are gone. The memories are all you have, and the plans will never come to fruition. The tears of gratitude turn to tears of sadness and despair. In what should be a time of joyous celebration, there is now devastation. She is gone, dead, and not from anything you might expect, but because she fell victim to the plight of so many in the United States. She became pregnant and did not survive to mother her child. Now, open your eyes. The dates on a baby's birth certificate and a mother's death certificate should be decades apart, not hours or days. According to the Centers for Disease Control and Prevention, maternal mortality describes the death of a woman while pregnant or within 42 days of the termination of a pregnancy, not due to accident or incident. The postpartum period is defined as up to 42 days or 6 weeks following birth. The United States has the highest maternal mortality rate of any developed country. National Vital Statistics System reports show that maternal mortality rates in the United States have nearly doubled from 17.4 in 2018 to 32.9 per 100,000 live births in 2021. Within the United States, rural communities within states of the Deep South experience the greatest maternal mortality rates. Listed in descending order of maternal mortality rate, the top 5 Deep South states include Mississippi, Alabama, Louisiana, Georgia, and South Carolina. More than 80% of maternal deaths are preventable. 80%. Each of the states of the Deep South are represented in the top 7 states with the highest populations of Blacks. Vermont, Wyoming, Maine, Rhode Island, and New Hampshire are the states with the lowest maternal mortality rates and some of the lowest percentages of Blacks within the population. Is this a coincidence, or are there other factors at play? After learning this information, I had questions and I wanted answers. I began to ponder 3 main questions. What are the root causes and contributing factors of maternal mortality? What postpartum care programs currently exist to support mothers in their postpartum period? And how effective is the village or community-based approach to postpartum care in reducing maternal mortality? Through stories told by word of mouth, documentaries on the Discovery Channel, and even movies, we can see that different family groups and cultures may have different methods of caring for moms and babies during pregnancy, delivery, and postpartum. When considering other countries with lower maternal mortality rates, the big question that came to my mind was, what are they doing that we're not? Next, I asked the question, what can I do to help? Better yet, what can we do? Because the resolution to this problem is not a one-man effort. From healthcare administrators to policymakers to healthcare providers and the like, everyone has a role to play. No one wants to picture their lives without their loved ones. So consider what a burden it must be to grapple with the actual loss of a loved one, especially when it may have been prevented. With a problem this big, where do we even start? The beginning is always a good place. Curiosity led me to ask, when did this issue of maternal mortality begin? The earliest data I found is from the early 1900s. Maternal mortality rates rose as high as 916.4 deaths per 100,000 live births in 1918. Many deaths were a result of postpartum infections, preeclampsia, hemorrhage, cephalopelvic disproportion, and the use of non-sterile obstetric instruments. Fast forward to present day. There are disparities in social determinants of health that occur due to the inequality in wealth, power, and resources, which often lead to poor or limited healthcare, education, housing, nutrition, and health outcomes. Patients' health outcomes are often impacted by healthcare systems and providers. For example, conducting medically unnecessary cesarean sections, failing to provide timely referrals, and writing unnecessary referrals can all negatively contribute to maternal outcomes. Evidence supports a critical need to address the social determinants of health that tend to have a greater impact on minorities due to a history of policies that acted in favor of white populations. Social determinants of health also are often seen in combination with other types of social determinants of health. These interwoven circumstances can play a crucial role in the outcomes of pregnancy. Community based organizations and birthing centers, with an emphasis on bringing care to Black pregnant and postpartum mothers, have been helpful but lack financial support to sustain their efforts. It is known that maternal mortality has been a problem for decades. Current strategies to address the problem include the extension of Medicaid coverage for postpartum women, comprehensive reproductive health care, coverage for midwifery services, and comprehensive postpartum support. Medicare for All, which contains accommodations for those with disabilities, allows for lifelong coverage and management of chronic conditions. Individual states have utilized evidence based approaches such as payment reform, various models of care delivery, managed care organization reporting requirements, midwifery led care, doula services, postpartum coverage expansion, changes in telemedicine, and bias prevention training for providers. Some other programs, policies, and initiatives target maternal mortality by providing resources for African American women, addressing the need for a mental health hotline, and providing funds for community based maternal health programs. In the Deep South, the leading causes of pregnancy related deaths in the top 5 states include cardiovascular conditions, infections, and hemorrhage. Some additional causes are unique to specific states. In Mississippi, it is hypertension. COVID-19, mental health conditions, and embolism are cited as causes in Georgia, while cardiomyopathy and accidental overdose are unique to Louisiana. Black patients in the Deep South report having their direct questions and concerns ignored on a regular basis, being refused medications for pain, being blamed for health issues, and having unfavorable assumptions made about them. Moreover, 18% of Blacks experience unfair treatment more often compared to other races. There is a connection between maternal mortality and postpartum care. Data reveals that nearly 40 to 50% of women do not routinely receive postpartum care from a provider. Historically, new mothers typically have only one postpartum visit between 6 and 8 weeks. So, we know the history, we have the data, we know what has been attempted to solve the problem in the United States, but what occurs in other countries? People in some countries like China, South Korea, India, and Australia engage in both traditional and modern practices. Each country practices a confinement period. While they are not identical, some of the features include no or limited visitation, massages, postpartum care, and nutrition, sharing experiences, and having care provided by family members. The duration of the confinement period also varies between 21 and 40 days. Confinement may be in the mother's home or care center. In a study evaluating postpartum care in African countries, counseling, health literacy, and education were among the examined interventions. Mobile health is another avenue that offers many benefits. Mobile health interventions aimed at targeting health literacy have been employed in sub-Saharan Africa and Southern Asia. Educational resources were provided through text and voice reminders. In Ghana, mobile health interventions were used to increase utilization and continuum of care for maternal and child health. In the United States, mobile health clinics and devices have been useful in providing preventive, primary, and specialty service care through Mobile Health Map. The March of Dimes offers a mom and baby mobile service, a health center in select states, but none in the Deep South. From one side of the globe to another, mobile health interventions have had a positive impact. With all this information, what's next? Here's a thought. Provide mothers with what they need, utilizing a combination of strategies implemented from all over the world. It takes a village. It's not just a statement, it's a plan, a solution, a remedy for pregnant and postpartum mothers, an amalgamation of traditional and modern methods of maternal care. It Takes a Village is a one stop shop for maternal and postpartum care needs. In coordination with local hospitals, community health clinics, health related nonprofits, and small businesses, the Mobile Health Care Act can support the vision of making maternal health care accessible to women in rural communities. In this model, women will have health care provided by midwives, nurse practitioners, physicians, and or nurses. Additional services will be provided by nursing assistants, medical assistants, and volunteers. Mothers will have various aspects of their health, like mental and reproductive health and chronic illnesses, monitored, reported, and treated by their doctor. Pediatric health will also be monitored, reported, and treated. Nutrition, lactation, breastfeeding, massage, and temporary childcare services will be made available. Mothers can have a complete or modified confinement period, which will allow them to remain at home while aid comes to them. If developed within the confines or the context of a not for profit organization, funding and supplies can be procured through grants, partnerships, donations, and Medicare. The primary source of funding will be available through the Mobile Health Care Act, which expands access to mobile health services by funding mobile health units for Section 330 Health Center grantees. The Mobile Health Care Act is funded by the New Access Points Grant Program and managed by the Health Resources and Services Administration. Mobile clinics can cost upwards of $1 million to fund. This program can provide up to $650,000 per applicant. Habakkuk 2:2-3 says to write the vision and make it plain. In my vision, families are not torn apart as a result of poor or inadequate maternal or postpartum care that ultimately leads to maternal death. Quality economical postpartum care is accessible to low-income rural minority populations. Policymakers will make decisions and develop policies that support the reduction of maternal mortality. Health administrators and community health center leaders will work in cooperation to see the mobile health unit to fruition. Hospital and community maternal health care workers will promote It Takes a Village to patients. Healthcare professionals and community members will advocate for policy change that will provide care and funding. A service exists to safely bring mothers through postpartum. With no cares about travel time to see a doctor, it is a service that is a village. And in this village, mothers have their health monitored, time to rest, a nutritious meal prepared by someone else, and access to other necessary health related services. It takes a village. I see a solution, a village. Not just a term, not just in name, but a village in action, because it takes a village. Close your eyes again. Imagine your loved one back in your memories and plans for the future. Imagine that it was all able to happen because she received the care she needed, all because of It Takes a Village. Isn't she worth the investment? Open your eyes. Thank you for the pleasure of your time and attention. Before I close, I wish to offer a special word of thanks to all who have supported me on my doctoral journey. First, thank you to my family and friends. Your prayers and encouragement have blessed me in ways that are indeed immeasurable. To my coach, Dr. Lamarcus Wingate, and SME, Dr. Janine White-Harper, thank you for your guidance throughout my capstone process. To the DHA Program Director, Dr. Renita Waldrop, and faculty, your contribution, no matter the size, is appreciated. And for every encouraging word and opportunity to bloom, thank you, Dr. Angelita Howard, Dr. Dorothy Boldrick, and Dr. James Lillard. To the one without whom nothing would be possible, I give the utmost praise and thanks to my Lord, Jesus Christ. Thank you.
Hello, I'm Trishina Stokes, and the title of today's presentation is The Age of AI in Healthcare, a Strategy for Maintaining HIPAA Compliance with AI. Artificial intelligence is advancing healthcare, but is it doing so at the cost of patient privacy? Not long ago, I received a letter in the mail, one that you likely received as well. It was the breach notification letter from Change Healthcare letting me know that my personal information was compromised in a ransomware attack. This attack affected over 190 million individuals nationwide and is now considered the largest healthcare data breach in history. What's interesting about it is that most of the individuals affected by this breach likely can't even recall ever providing their information to the organization, yet it was shared as part of the treatment, payment, and healthcare operations disclosure, which permits the sharing of patient data without their consent or authorization. You see, Change Healthcare, which is a clearinghouse under the United Health Group, is one of the largest health payment companies in the world. This means in the background of your care, they manage payments and revenue cycle processes for insurance payers, providers, and patients. Change Healthcare is said to process about 50% of medical claims in the US. That's claims for about 900,000 physicians and roughly 15 billion healthcare transactions annually. This massive breach disrupted operations, leaving countless patients unable to access essential prescription medications. Those who could afford to pay out of pocket for their expensive drugs did, but those who could not afford it were also unable to use their discount pharmacy coupons due to system outages caused by the breach. This data breach of a technology that was meant to improve healthcare operations left many economically disadvantaged patients without the medications necessary for their well-being. This same breach also led to more than $9 billion in loans to healthcare providers who could not bill or receive payments for their services because they lost access to essential systems. Patient care was delayed, provider payroll was disrupted, and many of the providers that you go to for care needed care for themselves for the mental and physical health challenges that arose from not being able to meet their own needs. Just as in the case of the Change Healthcare breach, technology has been at the center of healthcare data breaches for decades. Hacking, ransomware attacks, unauthorized access, and other information technology-related incidents are the leading cause of healthcare data breaches. In fact, last year, in 2024, data security breaches within healthcare organizations represented 81% of all breaches across all industries, resulting in the exposure of more than 250 million patient records. Artificial intelligence, the latest technology on the field, is advancing healthcare, but is it doing so at the cost of patient privacy? Today, we will explore how to ensure that patient privacy is not the currency for AI in healthcare. First, we will delve into the HIPAA legislation and what it means to be HIPAA compliant. Next, we will clarify what AI is and examine how it is currently being used in healthcare. Then we will discuss the costs associated with HIPAA compliance and how other agencies are addressing AI. And lastly, we will provide recommendations to minimize the risk of non-compliance with HIPAA. So you may be wondering, what is HIPAA? HIPAA is the Health Insurance Portability and Accountability Act. This federal legislation was enacted in 1996 during the rise of the electronic health record to increase the portability of insurance, to prevent the loss of health coverage during job change or layoffs, and to offer privacy protections for health information. Healthcare has evolved quite a bit since 1996, and so has HIPAA. Since its inception, HIPAA has adapted to the changing landscape of healthcare, and is now what many know as a leading standard for outlining lawful uses and disclosures of protected health information. Today, the PHI, the protection of PHI, is backed by 3 rules. You have the HIPAA privacy rule, which specifies certain uses and disclosures of PHI that do not require an individual's consent. The HIPAA security rule, which establishes administrative, physical, and technical safeguards to prevent unauthorized access, use, and disclosure of PHI. And the breach notification rule, which mandates that healthcare entities notify individuals when their information is compromised due to a breach. Overall, to be HIPAA compliant essentially means that measures and safeguards have been established to prevent the unauthorized disclosure of PHI or protected health information. Now let's talk about artificial intelligence. AI is generally described as the ability of a system or machine to perform cognitive human-like functions. Think of it as a technology that's learning, interacting, solving problems, and making decisions. Sounds pretty human, right? Well, this human-like technology has been used in various capacities within the healthcare industry for over 50 years. In the 1970s, an AI program named MySyn was created at Stanford University to determine treatments for blood infections by applying learned rules and analyzing disease data. Later in the 1980s, AI contributed to the diagnostic decision support system known as DXplane, which generated potential diagnoses based on the symptoms provided. Then in 2018, the FDA approved an AI device for early detection of diabetic blindness through eye image analysis. And the following year, researchers at the University of Alberta in Canada used AI to develop an experimental bionic arm that adapted to and predicted an amputee's movements. From remote patient monitoring that allows individuals to access care from almost anywhere, to the use of AI for detecting changes in vital signs, technology is transforming healthcare. For instance, an AI-enabled remote pulse oximeter can alert a care team about abnormal oxygen levels in a patient with chronic obstructive pulmonary disease, allowing providers to intervene from a distance and helping to prevent significant medical issues or even the need for hospitalization. So there's no doubt about it. Artificial intelligence is indeed advancing healthcare. However, I must ask, is this progress being made at the expense of patient data? Today, AI is not only trained on standard textbook medical data, but potentially on information that includes protected health information. There are 3 primary types of artificial intelligence. You have machine learning, natural language processing, and deep learning. Machine learning is being used to analyze electronic health records, helping to predict mortality rates and identifying patients suffering from various conditions. Natural language processing their tools process and comprehend human language and generate relevant and understandable responses, such as in the case of chatbots that serves as interfaces for patients to ask medical questions. You might see these on some hospital websites or portals. Deep learning, a subset of machine learning, analyzes raw data to uncover patterns and detect abnormalities for disease prevention. For instance, deep learning technology has been used to assess surgeon performance by examining surgical videos, ultimately enhancing surgical efficiency. So you may be asking yourself, what is the point of this discussion if AI is enhancing healthcare? And that's a pretty good question. However, the focus of this talk is not solely on the advantages of AI and what we understand about it. Instead, this talk centers on what resources are needed to promote HIPAA-compliant use of AI in healthcare. Is AI advancing healthcare at the expense of patient data? Is AI being trained on unredacted PHI, exposing the sensitive information of patients who trust healthcare systems? Will AI or AI developers become the next source of vulnerability that results in a significant healthcare data breach, one that rivals or surpasses the impact of the Change Healthcare breach? Another reason why we're having this conversation is because HIPAA breaches are expensive. Non-compliance with HIPAA may lead to civil or criminal penalties. The Office of Civil Rights may impose civil monetary penalties ranging from $100 to $1.5 million. HIPAA violations with criminal intent can result in penalties up to $250,000 and 10 years in prison. The Change Healthcare breach cost United Health Group approximately $2.8 billion. So healthcare organizations not only take a financial hit when a breach occurs, But data breaches can also disrupt supply chains and negatively impact operations, creating financial barriers and severing patients' trust in healthcare organizations. Patients really are at the center of it all. A breach of PHI can violate a patient's right to privacy and compromise their confidentiality of their social security number, their date of birth, and address, making them vulnerable to identity theft and other fraudulent activities. So I don't know about you, but I'm a patient of my healthcare organization, and so are my children, my husband, my neighbors, and friends. The people we care about are on the other side of our compliance with HIPAA. And our failure to ensure that their information is protected with the use of AI could be devastating. Compromised electronic health records can prevent doctors and nurses from quickly accessing critical information, ultimately affecting diagnosis, treatment, and overall patient outcomes. The rapid expansion of AI in healthcare highlights the need for regulations and policies to govern privacy and security measures, and some agencies are doing the work. The Centers for Medicare and Medicaid Services has updated coding and reimbursement methodologies to include AI-enabled products. The Office of Human Research Protections, they have discussed the impact of AI on the protection of human research subjects. And in 2019, the Department of Veteran Affairs launched the National Artificial Intelligence Institute as a collaborating organization for AI research, implementation, and policy. And the Office of the National Coordinator for Health IT implemented changes to the 21st Century Cures Act to include AI algorithm transparency. Although recent executive orders under the Trump administration might hinder this progress. The European Union adopted Artificial Intelligence Act to impose safeguards on their use of AI. They also banned AI applications that use biometric data, including those used by law enforcement. And the National Institute of Standards and Technology, also known as NIST, developed the Artificial Intelligence Risk Management Framework to encourage responsible and trustworthy use of AI. So governments and other organizations are calling for more stringent regulations on artificial intelligence. And I believe healthcare leaders should do the same. I have done the research, and the data shows that establishing a regulatory framework for privacy and security legislation regarding the use of AI in healthcare is proposed as a solution to support HIPAA compliance. This is why I'm recommending that we use the well-established Office of Inspector General's 7 elements of an effective compliance program as a model framework for maintaining HIPAA compliance with the use of AI in healthcare. The 7 elements of an effective compliance program are implementing written policies and procedures, designating compliance leadership, training and educating staff, developing effective lines of communication and reporting, monitoring and auditing, enforcing standards, and responding to issues. Now, while not all 7 of these elements align with every healthcare facility's existing organizational structure, 5 of them resonate pretty well with the literature and can be modified to address concerns regarding the protection of AI, of PHI with artificial intelligence. To help provide some context, a little bit more context to this message, I'm going to shift the focus for just a minute, so stay with me. Are you familiar with the book, The 5 Love Languages by Gary Chapman? It has been a bestseller for over a decade with more than 20 million copies sold. This book outlines 5 ways to express love that have transformed relationships: acts of service, quality time, words of affirmation, physical touch, and receiving gifts. Now, I believe one of the reasons this book has done so well is because people have realized that relationships are essential to life. Well, if you really think about it, compliance is essential to the operations of healthcare. Compliance with state and federal laws that govern our operations. At the core of healthcare is the relationship between the patient and the provider, with providers including the healthcare systems and organizations that we represent. This relationship is built on trust. Patients trust that when they put their care in our hands, we're going to do what the law says we should do to protect their information. And where law is void, they trust that we will exercise our due diligence to do what is ethically right. So I'm excited to share my recommendation for ensuring HIPAA compliant use of AI in healthcare. The 5 elements for HIPAA compliance with AI. This recommendation, which is to be adopted into existing compliance program operations, is just another way to say that we care about protecting our patients' data, we care about compliance, and here's what we're doing to prove it. The first element is implementing written AI-centered compliance policies and procedures. Policies and procedures generally serve to inform employees, contractors, and other stakeholders about how an organization will comply with laws and regulations. So here, the recommendation is to incorporate AI into existing policies and procedures and processes that support the creation, maintenance, use, and disposition of AI-affiliated data that contains PHI. The second element is to designate AI compliance leadership. This element focuses on assigning responsibility for AI compliance activities to someone such as a new or existing compliance officer. It also encourages the formation of a compliance committee to discuss and manage AI compliance activities from an interdisciplinary perspective. The third element is to provide HIPAA-compliant AI training and education to staff. The OIG states that all board members, employees, contractors, and medical staff should complete at least annual training regarding an organization's compliance program and their potential risk. Therefore, it is recommended that current compliance training be revised to outline the organization's standards for HIPAA-compliant use of AI tools and systems. The fourth element is auditing and monitoring AI risk. Again, the Office of Inspector General recommends that organizations perform routine monitoring through an internal risk assessment at least once a year. The recommendation here is to incorporate the assessment of potential AI risk when evaluating patient data privacy concerns. An example includes conducting random samples of AI data outputs to verify that PHI is shared as intended and adheres to minimum necessary requirements, as well as routine examination of software sanitization procedures by AI developers and vendors. The fifth and final element is responding to AI compliance issues. This element recommends the development of a process for addressing AI risk and implementing corrective actions. Compliance programs must clearly define steps for correcting non-compliance issues in their policies, as well as the proper procedures for reporting to government agencies when necessary. Numerous healthcare organizations already operate with a compliance program that aligns with the OIG's 7 elements. Therefore, adopting this strategy should be seamless for most. When evaluating the cost of this recommendation, consider your organization's size, training expense, and costs related to auditing software or consulting services if employed. Most healthcare organizations already have compliance measures in place. Therefore, again, the cost of implementing this recommendation is minimal. There's also the potential cost of a HIPAA breach. Direct costs for breaches affecting 500 or more individuals includes forensic assessments, hotline services, credit monitoring, and while indirect costs include internal investigations, reputational damage, and the loss of patients' trust. HIPAA violations can lead to fines from $140 to $2 million and potential imprisonment. Speaking of costs, artificial intelligence is advancing healthcare, but do you know if it is doing so at the cost of your patient's privacy? This is a cost you definitely want to avoid, and fortunately, you may be able to if you adopt the recommended framework of the 5 elements for HIPAA compliance with AI. I believe this framework can help ensure that your organization's use of artificial intelligence remains compliant with HIPAA. I would like to thank the Lord for sustaining me through this doctoral journey. Thank you to all Morehouse School of Medicine DHA faculty. Thank you to Dr. Waldrop, and thank you to Dr. Jasmine Agnew, and a special thank you to my Capstone coach and mentor, Dr. Anthony Houston. Additionally, I would like to thank all of my family and friends who have prayed for me and supported my studies and encouraged me along the way. Thank you all.
Good evening, everyone. My name is Pamela Woods, and today I want to bring attention to a silent crisis, one that hides behind smiles, resilience, and the myth of unbreakable strength. It is a crisis affecting our fathers, sons, brothers, and friends. It's the mental health battle faced by African American males. As I begin my story, I want you to imagine this. It's October 2002. You're pumping gas, loading groceries into your car, or simply walking down the street. Then suddenly, without warning, bang, a shot rings out. Another person is dead, then another, and another. Washington, D.C., Maryland, and Virginia are paralyzed with fear as the unknown assailant strikes seemingly at random. Schools go on lockdown. People zigzag through parking lots, terrified of standing still for even a moment. The entire nation watches in horror. And when the killers are finally caught, the truth is even more chilling. The culprits: John Allen Muhammad, a 41-year-old Gulf War veteran, and Lee Boyd Malvo, a 17-year-old boy he had manipulated and groomed. Malvo, abandoned by his parents and bounced between unstable homes, desperately searched for a sense of belonging, only to find it in the hands of a man who turned him into a weapon. Muhammad, burdened by past traumas, personal failures, and untreated mental illness, saw in Malvo not a lost boy, but an opportunity. This is the story of the DC snipers, a chilling reminder of the devastating outcomes that can arise when mental illness and trauma go untreated. But beyond the horror of their actions, this story exposes a deeper issue: a mental health system that fails to recognize and address the unique challenges faced by African American males. Let's look at the facts. According to the American Journal of Public Health, African American males are more likely to experience chronic stress and trauma, but 50% less likely to receive mental health treatment compared to their Caucasian counterparts. This disparity isn't just a statistic. It is a systemic failure with real and sometimes tragic consequences. Now, imagine growing up with no stability, constantly abandoned, shuffled between homes, never knowing where you truly belong. This was Malvo's life, a childhood devoid of consistency, security, and most importantly, the support he desperately needed. Research from the American Journal of Preventive Medicine reveals a harsh truth. African American adolescents who experience multiple relocations are at a much higher risk of developing behavioral issues and mental health disorder. But here's the problem: these kids don't receive the care that they need. Instead, they're punished, they're criminalized, they are labeled as problems, when in reality, they're just kids in pain. Then there's Muhammad, a veteran who didn't just fight overseas, but in the years that followed. He struggled the unspoken scars of post traumatic stress syndrome, or PTSD for short, and the burden of systemic racism. His experiences highlights a significant issue. According to the US Department of Veteran Affairs, despite facing higher rates of PTSD, African American veterans are less likely to receive treatment compared to Caucasian veterans. Muhammad returned from war to a country that saluted his service but ignored his suffering, honoring his sacrifice while overlooking his pain. But this isn't just about Muhammad and Malvo. It's about a mental health system that continues to fail African American males. And there are several factors that contribute to the deep disparities we see in mental health care. But today, I will discuss one of the most significant issues: historical mistrust. And let's look at a glaring example: the Tuskegee syphilis study. From 1932 to 1972, 600 African American males were deceived and denied treatment for syphilis, even when penicillin, the known cure, became available. This wasn't just unethical, it was deliberate betrayal. And the impact of this betrayal still lingers today, shaping healthcare decisions, trust in providers, and mental health engagement among African American males. A Commonwealth Fund post found that 55% of African American males distrust the mental health care system, often feeling misunderstood by providers. And when patients don't feel heard, they're less likely to stay in treatment. And the consequences are real. Research by Aurora and colleagues published in the Administration in Policy and Mental Health Journal found that nearly 2/3 of racial and ethnic minority males drop out of therapy early due to weak therapeutic relationships, lacking trust and relevance. But the issue goes deeper. It's also about who's providing the care. Only 4% of psychologists and 5% of psychiatrists in the United States are African American. Yet 50% of patients said they feel more comfortable with a provider who shares their racial and cultural background. That's a massive gap. And this isn't just history, it's happening now. In 2023, Pew Research study found that 50% of African American males had negative healthcare experiences, rising to 55% in 2024. Among them, 32% felt rushed, and 29% felt disrespected or received substandard care. These aren't just statistics, they're barriers. Barriers that keep people from seeking help. Barriers that reinforces a cycle of silence. So how do we change that? The solution begins with a fundamental shift in perspective, one that truly integrates cultural competence into mental health care. A shift that goes beyond intentions and turns into meaningful action. And today, I want to highlight 3 approaches: culturally adaptive cognitive behavioral therapy, or culturally adapted CBT for short, ethnic matching, and the Afrocentric worldview. But let's take a moment to define cultural competence, because before we go any further, I want to be clear. Cultural competence isn't just a trendy buzzword. It's not about avoiding stereotypes or memorizing facts. It's about transforming mental health care to truly reflect the diverse society we live in. Cultural competence means understanding, respecting, and integrating a patient's cultural background into every aspect of care. It's about fostering trust, enhancing communication, and understanding that mental health doesn't look the same for everyone. Now, picture walking into a room and truly seeing a person, not just their symptoms, but their lived experiences, beliefs, and challenges. That's cultural competence. It's acknowledging that every individual carries a unique story, and those stories must be valued and integrated into care for it to truly be effective. Let's begin to discuss why cultural competence is important. When care is culturally tailored, patients are more engaged and more likely to follow treatment. A meta-analysis published in the American Journal of Community Psychology by Greiner and Smith found that culturally competent interventions can increase effectiveness by 40%. That's the difference between receiving care or walking away. Now, imagine feeling unheard at a doctor's office. A simple shift in training could change that. A study in the Academic Medicine Journal by Lai and Bacher found that providers who receive cultural competence training develop more inclusive attitudes, leading to higher patient satisfaction, greater trust in providers, and better treatment adherence. The question isn't if cultural competence matter, because we know it does. The real challenge is ensuring every provider is trained to deliver it. Now let's talk about culturally relevant approaches. Now imagine therapy that doesn't just treat symptoms, but truly sees the person, integrating culture, identity, and lived experiences into healing. That's the power of culturally adaptive CBT. Studies have consistently shown that culturally adaptive CBT is highly effective, especially for African American males. Let me give you an example. In the study in the American Journal of Men's Health, Okoro and his colleagues found that culturally adaptive CBT led to a 12.6-point reduction in depression scores, more than twice the improvement of traditional CBT. Another story by Okoro and his colleagues, integrating African identity, spirituality, and community values, saw an even greater impact. Depression scores dropped by an average of 13.5 compared to just 6.5 points with traditional CBT. This is just not improvement. This is transformation. And let's take it a step further. A meta-analysis conducted by Huey and colleagues, published in the Annual Review of Clinical Psychology, offers even more compelling evidence supporting this approach. They found that culturally adaptive CBT was 4 times more effective than conventional methods. Now, let's look beyond the clinical trials, because what's even more powerful is that culturally adaptive CBT is not just working in research labs. It's proven its impact where it matters most, in the very communities that have been long overlooked and underserved. A community center in Baltimore saw a 55% reduction in emergency room visits when using this approach. That's just not helping individuals, it's changing the healthcare system. It's reducing strain on emergency rooms, saving resources, and proving that culturally competent care doesn't just work, it works better. But this is more than just symptoms management. It's about empowerment. Culturally adaptive CBT helps individuals navigate systemic challenges, reshape internalized beliefs, and foster resilience. It's not just better care, it's the care that's needed. One promising solution in mental health care is ethnic matching, pairing clients with therapists of the same racial and cultural background. A meta-analysis by Cabrile and Smith, published in the Journal of Counseling Psychology, found that African American males had the strongest preference for racially matched providers, with an effect size of 0.87. But it's not just preference, it's results. Matched clients reported better therapeutic outcomes and higher satisfaction. And the impact goes deeper. A study by Barakai and Hall, published in the Journal of Social and Clinical Psychology, found that African American males were 10 times more likely to discuss substance abuse with a racially matched therapist. Now think about that. 10 times more likely to open up, to seek help, and to take the first step towards healing. That's huge. And there's more. A study by Brandau and Schwarbick, published in the Journal of Psychiatric Services, found that African American males disclosed more daily stressors when speaking with a therapist who shared their racial backgrounds, showing how cultural connections foster trust. But wait a minute, there's a twist. Not all studies agree. In the Journal of Community Psychology, Meyer and Zane found that African American male adolescents improved more in self-control training when paired with Caucasian peer models rather than the same race peers. So what does that tell us? This is just not about race. It's about connection. Sometimes shared backgrounds builds trust. Other times, different perspectives sparks growth. But the key is knowing when and where it matters most. Now let's take a look at the final option. Every culture has a unique way of seeing the world. For African Americans, the Afrocentric worldview, rooted in African heritage, values, and traditions, shapes identity, resilience, and coping strategies. But don't take my word for it. Let's look at the science. Nebelik and his colleagues, in a study published in the Journal of Counseling Psychology, found that African American male college students who embraced the worldview were more resilient to stress and less likely to experience depression. Those that didn't, their depression risk increased with stress. And it doesn't stop there. Walker and his colleagues, in a study published in the Cultural Diversity and Ethnic Minority Psychology Journal, discovered that while depression levels were similar across African American and European American males, African Americans reported more reason for living, reinforcing the power of cultural identity in fostering hope and purpose. But it's not a one-size-fits-all solution. A National Institute of Mental Health study found that while the Afrocentric worldview approach builds resilience, only 55% of African American males felt it fully addressed the mental health needs. However, when culturally adapted CBT was introduced, satisfaction jumped by 70%. So, what does this tell us? It tells us while an Afrocentric worldview approach might be meaningful and effective for one person, it might not resonate so deeply with someone else, even if they share the same cultural background. Throughout this discussion, we've explored culturally adaptive CBT, ethnic matching, and the Afrocentric worldview, each offering valuable insights. But when it comes to effectively supporting African American males, culturally adaptive CBT stands out as the most impactful approach. Here's why. First is deeply personal. It goes beyond simply acknowledging ethnicity. It considers the full scope of an individual's experiences, from family dynamics and spirituality to personal values. It's not about placing people where we think they should be. It's about meeting them where they are and working with them in a way that truly resonates. Second, it builds on cultural strengths. For African American males, therapy isn't just about addressing struggles, it's about embracing identity. Culturally adaptive CBT creates a space where individuals can explore how their cultural background shapes their thoughts, emotions, and behavior. It shifts the focus from fixing to empowering, recognizing that culture isn't a limitation, but a source of resilience. And finally, the results speaks for themselves. This approach isn't just about reducing symptoms. It fosters trust, increases engagement, and equips individuals with tools to take control of their mental health. It empowers them to navigate life's challenges with confidence. It's not just in therapy, but in every aspect of life. One of the biggest concerns about implementing culturally adaptive CBT is cost. Critics argue that adapting therapy to be more culturally responsive requires additional training, resources, and personnel, all of which demand financial investments. And they're right. There are upfront costs. But the real question isn't whether we can afford to implement culturally adaptive CBT. It's whether we can afford not to. So let me quickly break this down. Training clinicians in culturally competence, racial trauma, and community-specific stressor takes funding time. Developing therapy materials that reflect diverse cultural narratives requires investment. Hiring and retaining mental health professionals from diverse backgrounds so that therapy isn't just being translated, but truly understood adds another layer to cost. But while the initial investment may seem high, the return is undeniable. When therapy fails to connect, people disengage. When people disengage, conditions go untreated. The results in higher rates of this results in higher rates of hospitalization, increased disability claims, and overburdened healthcare system. By investing culturally adaptive CBT, we're not just improving engagement, we're reducing the financial burden of untreated mental illness. Now, as I come to an end of this conversation, one thing is clear. The future of mental health care, especially for African American males, depends on moving beyond outdated one-size-fits-all models. Historical mistrust has left deep scars, creating skepticism toward the mental health care system that we cannot ignore. Now, let's take a moment to reflect, not on the actions of the DC snipers, but on the untreated trauma and societal alienation that were overlooked. Their story is a powerful reminder of what happens when we fail to address mental health. When people are unseen and unheard, pain doesn't just go away, it manifests in ways that can be devastating. This isn't about excusing actions, It's about recognizing systemic failure. It's about understanding that mental health struggles don't disappear when we choose not to see them, they grow. So, where do we go from here? The need is clear, the data is compelling, and the impact is undeniable. But change doesn't happen on its own, it starts with us. If you are a mental health professional, I challenge you to broaden your approach. Seek out cultural competence training. Learn from your clients, not just about them. Embrace the complexity of their experiences. If you are an educator or policymaker, advocate for inclusive mental health curricula and policies that dismantle systemic barriers. We must build a mental health system that doesn't just treat symptoms, but uplift and empowers the whole person. And if you're someone struggling with mental health, know this: your voice matters. Demand culturally relevant care. Your experiences are valid. You deserve support that resonates with you, with who you are. Together, we can transform mental care into a system that truly sees, hears, and heals everyone. Let's not wait. Let's take action today to create a world where mental health is inclusive, effective, and accessible for all. The journey to change begins now. Are you ready to take the first step? I want to thank God for allowing me this opportunity. This has been my lifelong dream, and I finally get a chance to see it come to fruition. I want to thank my mom. I want to thank my son who stood by me throughout this process. I want to thank the faculty, Dr. Waldrop, Dr. Lillard, Dr. Howard, who actually developed and created this program that allowed me the opportunity to be a part of it. And I want to provide special thanks to my coach, Dr. Erica Sutton, who pushed me so hard to this point. And I just want to say thank you to everyone who was involved in my life and for helping me make it to this moment. Thank you.
Well done, well done, well done. Thank you to all of the students who have presented. We are now going to invite all of the students back to the stage for a question and answer portion. So for all of our viewers watching on YouTube, now is your time. Please drop a question if you have a question about any of the presentations into the chat, and I will make sure to share that on our screen for everyone to see. So if anyone has any questions for the scholars, now would be time to drop a comment in the chat on YouTube. Well, in the meantime, you all have some wonderful affirmations from your colleagues as well as some viewers, and I'm just going to take a moment to share some of those. Capri Bell. So congratulations, scholars. I'm now going to invite Dr. Dorothy Boldrick to the stage for closing remarks.
Good evening, scholars. What an amazing display of scholarly achievement. As I was listening to your presentations, I was reflecting back on the first time that we met. And as an educator for many years, what I know to be true is that education at its best is transformative. And that transformation has been on full display tonight. I want to congratulate all of you for the amazing work that you have done in this program. I want to congratulate you on your perseverance and this major milestone that you have accomplished tonight. I'm going to keep my closing remarks short because I feel the ugly cry coming. And I don't want you all to see that. But I am just so proud of all of you and all that you have done, this major accomplishment. And I thank you for allowing me to be a part of this journey with you. Thank you all so very much. And you did an amazing job tonight. And I'm looking forward to all of the other presentations from our other cohort members as we finalize this journey to that major milestone of you becoming a doctor of health administration. So I would like to say good evening to everyone. Have a wonderful evening, and we look forward to seeing you as we continue with our amazing scholars as they present their culminating capstone projects for the completion of our Doctor of Health Administration program here at Morehouse School of Medicine. Thank you.